So the last case is I was just going to do a show and tell. I don't have any questions for this one. I thought this was just interesting. So I'm actually, in the interest of time, I'm just going to jump to, so this patient was called back for a very small group of calcifications in August of 2016. I'll mag those up here. Hopefully those project okay. Very small, just a couple of calcifications. She was called back for those. A stereotactic biopsy was recommended. I'll show the lateral magnification view. And there they are. So like I said, a stereotactic biopsy was recommended, and the patient did not want the biopsy and agreed to come in for follow-up. She was a little bit late coming in, but did come back. And you can see, or hopefully you can see, they just increased in number just a little bit. I think it shows here better. Again, a stereotactic biopsy was recommended, and the patient at this point declined again and was lost to follow-up for about a little more than a year. And then somehow she got scheduled for a screening mammogram. And this is we called her back because now where she had those calcifications, the calcifications have decreased in number, and now she has a mass. So here's the ultrasound showing that hypoechoic mass. I'm not sure why it's not scrolling. I can show the clips. I'm sure this shows it better. And now she has a hypoechoic irregular mass with angulated margins. And this underwent, now she agreed to undergo ultrasound guided biopsy. And of course that showed a grade 2 invasive ductal carcinoma. And she was noted to have multiple foci of DCIS in the area as well. So this is just a nice example of disappearing calcifications, which is a very rare phenomenon. But I have seen this case, and I have one other case that I've seen of this where the calcifications probably were in ductal carcinoma in situ, which continued to progress and ultimately become an invasive cancer, which resulted in some of the calcifications being sort of resolved or dissolved by the growing cancer. And that is all I have for this case review. Moving on to the next case. So the history here, I'm going to start with the 2011 exam. This patient had, at this time, was 44 years old and had a palpable left breast lump. And we had some images, we had some difficulty getting the static images to work and be de-identified. So what I'm going to show you here is the cine clip. The mammogram was done and just showed a large, well-circumscribed mass. So I'm going to show you this cine clip, and over here is the measurements of this mass that you'll see. So there's the mass. I'll pause it. Get back to those measurements. So again, the measurements were 3.9 by 3.3 by 1.3 centimeters with a volume of just under 9 cc's. So this underwent ultrasound guided biopsy and was shown to be a simple fibroadenoma. And she just returned to clinical and annual screening follow-up. In 2014, she saw another primary care provider who felt this mass and thought, well, let's just take another look at this. It's been a couple of years. So again, the initial biopsy was January 2011, and this is July of 2014. So you can see I put the measurements here. So to refresh your memory, it previously measured 3.9 by 3.3 by 1.3 centimeters. And the volume previously was almost 9 cc's. So it did get a little bit bigger, mostly in one dimension, maybe a little bit in the other dimension. But this was quite mobile, and that was felt to be part of the difference. So I'll show you the clip here. And I think you can visually see it's a bit taller than it was before. Okay. So at this point, I'd like to show the polling question for this case. So what is the next best step in this patient? We've had about 3.5 years and a slight interval increase in size, maybe about 50% increase by volume, biopsy-proven fibroadenoma. Great. Okay, so pretty much everyone who answered wants to biopsy it again. And I will say, I think there's no clear evidence-based recommendation for what to do in this case. I will tell you, I was the one that interpreted this and felt like it was visible on the mammogram, and she could feel it and just said, I think it's an okay amount of growth, and let it go. Okay, and then I will just show you. So she ended up coming back about 10 months later. And this is what we saw. So this had rapidly increased in size. So per the patient, she really hadn't felt any changes until very recently after this, where this just rapidly increased in size. There was some history of possibly a mild trauma. So some thinking that maybe this could be hematoma, but because it was so suspicious and the patient really didn't have any bruising, she underwent biopsy, which was initially actually non-diagnostic, and she underwent subsequently a surgical excisional biopsy, which showed to be an aggressive malignant phylloides. So this is a very sad case. So I'll just start showing the MIPS here. So just as we saw in that MRI, this was benign over here, but just as we saw, on the ultrasound, there was a very large mass where this fibroadenoma had been. And here's the T2. The surgeon said when she went in and did the surgical excision, it was very soft, very soft tumor. So it showed pretty T2 bright here, almost looks like fluid with some fluid around it. And as you can see from the MIPS, it enhanced a lot. And here's the subtraction. Okay, I'll just show the post-contrast, which not surprisingly just showed a lot of enhancement. So, and there we go, lots of enhancement. And phylloides can have this kind of cleft. This is described at pathology, this cleft appearance, which I wonder if this is what we're seeing here on the MRI. I think the main teaching point with this is, with this case, I'm just going to bring this up again. Certainly going forward, this was a very large mass to begin with, and again, when I've looked into this, there's not clear guidelines set forth as to what size these should be removed. And I'm not sure, even if we had biopsied this in 2014, if we would have gotten phylloides. But I think at this point going forward, I certainly would have rebiopsied it, possibly just said, this is pretty big, it should just come out. Of course, this case influences me. And the pathologist actually went back and looked at the 2011 biopsy sample and said, no, it just looked like fibroadenoma. And it probably, fibroadenoma and phylloides are on the same spectrum pathologically, and there may just have been a small phylloides segment that kept growing and eventually became malignant. Okay, moving on to the next case. Okay, so this is a These images here are from a 38-year-old woman who noticed a right breast lump in the shower about a month ago. A little bit achy, but not particularly painful or tender. On physical exam, the nurse practitioner who she saw really didn't feel much, maybe a vague mass at 12 o'clock. Notably, the patient has a fairly significant family history in multiple maternal relatives. So maternal aunt, maternal great aunt, maternal grandmother, great grandmother. Her mother did not have any history of breast cancer and actually had been tested for the BRCA genes and was found to be negative. So again, this was a right palpable mass. I'll just show you the right side here. So there's the BB, and you can see she's very dense, and there's really nothing very visible on the 2D mammogram. And there's the MLO. We did do tomosynthesis, so I will. So again, we're going to be looking up in here. That's where the symptom, the lump is. Hopefully this will load. Okay, here we go. You can see maybe there's an oval mass there. But really not seeing much. I'll show the CC tomo. Okay, and again, we're looking at this 12 o'clock area. And there you can see partially, I would say, obscured, and what margins we can see look pretty circumscribed in a dense round mass. So of course we went to ultrasound. Okay, and I'm gonna just scroll through these ultrasound images. So here's what we're looking at. You can see very dark anechoic portion, pretty well circumscribed margins, and then this hypoechoic portion. We looked with very low flow sensitive settings to see if there was any flow in any of these peripheral hypoechoic portions, and we did not see any. She had no abnormal lymph nodes. And here's a cine clip. Which I think shows the characteristics of this very well. Okay, and again, there was no blood flow in any of those peripheral parts. Okay, so can I have the polling question for case 6? Thank you. Okay, so what do you want to do with this patient? 38-year-old, palpable lump. So is it a complicated cyst? Do you want to try and aspirate it, follow it, or just go straight to biopsy? Okay, great. So everybody wants to try to do some more diagnostic stuff. So looks like either attempt to aspirate it, and if it doesn't collapse, biopsy it, or just go straight to biopsy. Great. Okay, so what we did is I actually was the one that did her biopsy. And I wanted to try and aspirate it first. So I have an image here of this is actually me injecting lidocaine into the kind of capsule of it. So I'm going to play this for you. And I think this really nicely shows that the anechoic part is just kind of swirling around, but you can see there are these hypoechoic parts which really aren't moving at all. Okay, and then and this is after I gave the lidocaine, I attempted to aspirate. And you can see it did get smaller, but it did not collapse totally. So I went ahead and did a core biopsy. And this ended up being a triple negative high grade invasive ductal carcinoma. So you all made the right choice. So I was just going to show the MRI because I think it has some interesting and typical features of high-grade invasive ductal. So this is the T2 sequence. And not surprisingly, especially given the appearance on the ultrasound, there is T2 bright material that probably represents necrosis. You can see the marker clip from the biopsy, and the lesion is almost all T2 bright with some areas of very hyperintense T2, which probably corresponds to that necrotic material. But even the tumor itself is pretty T2 bright. And then this is the first post contrast. It did show some washout, and I'll just show you basically it shows rim enhancement, which also fits really nicely with the ultrasound appearance. So you can see here but the key differential here is that this rim enhancement here, it's pretty smooth and uniform, but here it becomes very thick and irregular. And near the top of it, it's thick and irregular. So that all fits really nicely with the ultrasound images. And she underwent neoadjuvant chemotherapy and had a complete pathologic response. So good news for her. Okay, so we are going to move on to the next case. So there's a couple good teaching points, I think, with this case. So what you should be able to see here is a left MLO view from a screening exam in 2021 with a prior from 2019. And the next most recent prior was from 2017. So just take a look here. Okay, I'm going to show the CC views now. So this is the left CC view from 2021. Okay. I'm sorry to keep everyone on their toes. I'm going to have, before we move on, I'm going to have people want to write in the chat, is there any area here that catches your eye that you want to take a closer look at, that you want to color back for? This is a tough case, and it may not be easy to see on the screen. So I was the one actually that read her mammogram, and what I thought I was seeing here was a really good example of an involuting breast. So the surrounding tissue out here is slowly decreasing in density, but there's basically this island of tissue here around 12 o'clock that is persistently dense and now appearing denser than the surrounding tissue. So again, I'll go back to those MLOs. And I think this shows it well as well. So again, the tissue is pretty uniformly dense here with this area looking similar to the surrounding tissue. You can also see we changed equipment between these 2 years. Same thing here, it looks pretty homogeneous. And then now this is just looking much denser. So I called her back and we did some additional views. So that was a 2D screening that we did. So it'll probably just take a moment to load. So we brought her back and did some tomosynthesis. There we go. Okay, so there's that denser area. And as I'm waiting here, basically the tomosynthesis kind of showed more of the same thing, that there was this denser area of breast tissue, maybe some distortion, nothing terribly striking though, just more of the same. So here we go. Just that kind of diffuse area of increased density. Okay, so I'll pause that. We also, of course, looked with ultrasound. And the ultrasound actually wasn't terribly impressive either, just basically showed this vague hypoechoic shadowing area. There we go. So more just sort of this vague hypoechoic shadowy area, large area. There should be there some more. So it's really this whole area. So the patient underwent an ultrasound guided biopsy using a 14 gauge needle, and the pathology came back atypical ductal hyperplasia with apocrine features, focally severe atypia, and sclerosing adenosis. And there was a note from the pathologist that the atypia ranged from mild to severe, and no necrosis was seen. The findings are quite atypical, but features, particularly in light of the apocrine cytology, are not sufficient for the diagnosis of ductal carcinoma in situ. So time for this polling question for case 5. What do you want to do with those RADPath results, those pathology results? How would you consider this in terms of concordance? Is this discordant? And what next steps would you want? Or do you think this is concordant and you want to do some follow-up imaging or just send her to surgical excision, given the fact that this atypia, sometimes severe, focally severe, was present? And I will say for this one, I think there's probably more than one right answer. Great. Okay, so everybody thought this was discordant. And these are exactly the two answers I was thinking. Either go to MRI to look for a better target to biopsy, or send her to surgical excision because we've already tried biopsying. Okay, great. So interestingly, what was done in this case is the radiologist who did the biopsy felt it was concordant and just sent her for surgical excision for atypia. And actually the radiologist who recommended the biopsy did not think it was discordant, so there was a difference of opinion. So the patient ended up getting a surgical excision, which did indicate that there was extensive DCIS. So I will show, so what you will see on the MRI when I show it here is that there are also post-surgical changes because the patient did have a excisional biopsy. So here's the post-contrast MRI. I'll just take a moment to load. I think the important thing here is that I would consider this discordant, especially when the findings are pretty vague and over a large area and you use a small 14 gauge needle. I think you could send the patient to excision, but I do think probably ideally getting an MRI first would be the best next step, because you could do an MRI guided biopsy actually similar to that case we just saw, get a better sample and hopefully get the DCIS, because this patient actually, as you'll see here, had very extensive enhancement and ended up getting a mastectomy. And the final pathology of the mastectomy showed over 5 centimeters of high-grade DCIS. So I'm going to try and window level this a bit, if I can. Well, I think you can see here. So she had surgery, so some of this skin enhancement and thickening is from the surgery, but you can see there's extensive enhancement involving most of the upper breast, which corresponds well, I think, to the mammographic finding. And then here's the MIP image. I think really nicely showing how extensive this is, involving most of the upper breast in this patient. Moving on to the next case. So you can start looking at these images. This patient had moved from Scotland and we had no prior mammograms on her. The symptomatic side was the left side here. You can see this BB marker here. So you can go ahead and start taking a look at that. And I will give you her history. So as I said, we had no recent mammogram. She is 55 years old at the time of presentation, and several months earlier had noted a tender, palpable left breast lump in her upper outer quadrant, about 1 to 2 o'clock, 4 to 5 centimeters from the nipple on the left, if I haven't said that already. She said that lump and tenderness resolved, and a little while later, she started noticing spontaneous bloody nipple discharge on the left. Subsequently, she found that she was able to reproduce consistently that bloody nipple discharge from a single duct when she palpated over the previous tender palpable area, which again had gone away by now. No family history of breast cancer. So I'm going to blow this image up so you can see a little bit more clearly. If I can. Okay, so again, here's the BB marker. She's pretty dense. This was just a 2D mammogram that we had. And I'll just show you in comparison. So maybe there's a little bit of an asymmetry in the breast tissue and a little asymmetry here. So we went ahead and did some additional views, which I will show you. So we did some spot compression views over that palpable area. And this was all interpreted as just dense breast tissue. So really, we didn't think there was any architectural distortion, no mass. Because of the nipple discharge, we also did magnification views under the nipple. You can see here, there's the BB marker again. We did not see any calcifications. It's another image, okay. And then we proceeded to ultrasound. And basically we did find some look like bland duct ectasia leading up to the nipple, but really nothing else. Again, that duct ectasia, but no intraductal masses. I'm going to show a cine clip here. This again just shows that duct ectasia. And again, we didn't think there was anything focal to biopsy. I'll pause that. Okay, so I'd like to put the polling question up for this one. So for this patient, just to review, we have a fairly suspicious clinical scenario. So the question is, what do you want to do in this patient? We don't see anything definitely by mammogram or ultrasound. So what is the next best step? Palpation guided biopsy, we can go off of where we can reproduce that bloody nipple discharge, duct excision for the bloody nipple discharge, MRI or clinical follow-up. Great, 100%. Everybody wants to go for the MRI. Perfect. So what we did is send this patient to our breast surgeon who did also a physical exam. And the discussion to decide to go to MRI basically revolved around the fact that this area was sufficiently far away from the nipple that doing a duct excision may not include the area where palpation yielded the nipple, reliably yielded the nipple discharge. Okay. So I think, again, in this case, the MRI MIP is the best demonstration of what we found at MRI, which was a significant amount of non-mass enhancement, all in that upper outer quadrant of the left breast, extending close to the nipple. And at this point, we did an MRI guided biopsy, which yielded DCIS, and the patient subsequently underwent mastectomy, and all that was found was extensive intermediate to focally high grade DCIS. So this is a striking case of mammographically negative, ultrasound negative, extensive DCIS, so non-calcifying DCIS. And I think this is an excellent use of MRI in a highly clinically suspicious scenario where the standard workup of mammogram and ultrasound is not revealing. So we're moving on to the next case, and you can see here on the left is the screening MLO image from the year before, and this is the current screening mammogram image. This is a 70-year-old woman who was, just like I said, undergoing screening mammogram. So take a look at these images. I'll also show you the CC. Okay, and again, this is the current screening mammogram image and the 1 year prior. And now I'm going to show you all 4. Okay. So please show the polling question for this exam. Okay, so after you've reviewed these images, what would you like to do with this patient? Would you like to bring her in for a diagnostic mammogram and ultrasound of the right breast and axilla, or just look only at the right low axilla? Or do you think this all looks fine and you just have her go back to screening? Or would you recommend an MRI off of the screening exam? Great, okay, so all of you want to bring this patient back and look at those axillary lymph nodes. And some of you also want to look at the right breast, so that's perfect. Okay, so we called her back, and let me pull up the ultrasound images. So I'm just going to show the ultrasound images. Those are what are most useful. Okay, so we looked in the axilla and we found these 2 areas and went ahead and we're planning to do a biopsy. Now, this is not a polling question, so let's see. Maybe we can have people vote in another way, but I want to know, was there any other area of the breast that you wanted to look at based on that mammogram? Let's see, I've got one right upper outer quadrant. So you probably are looking at this. Great. Anything else? I'll just give it a moment and then I'll move on to what happened in this case. Okay, so I am just going to move on. So when we brought this patient back, all we did was look at these lymph nodes. We didn't think there was anything else in her breast. And on the day of the biopsy, the patient actually said, well, what about this area and the inferior aspect around my nipple where I've had this discoloration and skin thickening? So despite having some new symptoms in her breast, she hadn't mentioned them to anyone, and including for the screening mammogram. So she mentioned this at the time of the biopsy. So we went ahead and looked at this area with ultrasound, and we found this mass that was partly going up into her nipple and extending inferiorly into the underlying breast tissue. So I thought this was an interesting case. It's a very subtle change. The 2 things I want to show are, I'll just go back and show the comparison images again. So I think this is a very subtle finding, but you can see there is a little bit of skin thickening and retraction right behind the nipple. This was the most recent exam that we did not appreciate right there. The other thing I thought that was interesting about this case is just to show how we biopsied this. So there again is the mass. We felt it was coming down into the breast tissue there. So that's what was targeted. And I'll just show you there's the lymph node biopsy, and then there's where we biopsied under the nipple. So this ended up being a papillary carcinoma that arose in the nipple and metastasized to the lymph nodes. And I'll just show you, I think the best image on the MRI is the MIP. You can see this marked enhancement at the base and extending into the nipple, very asymmetric with the other side. And again, this is the right side, and then you can see those lymph nodes up there. Okay, so we're going to move on to the second case. So you can start by looking at the images here. First, I'll just indicate that the image here on the far left is the MLO from about 2 years earlier. This was the next screening mammogram from about 5 months to the symptomatic diagnostic mammogram, and I'll go over the symptoms in just a moment. So again, this was in August, and this was back in May, and this was, I believe, about a year earlier. So take a look at the images. The history here is this is a 75-year-old woman with new painless left breast reddish purple discoloration and edema over about a 6-week period over the predominantly inferior aspect of her left breast. And again, this is the, if I didn't say so, this is the left breast I'm showing here. As you can see, there's some surgical clips and a scar marker. She does have a history of approximately 8 years earlier, triple negative stage 1A breast cancer for which she underwent partial mastectomy, radiation, and chemotherapy. On physical exam, the skin discoloration was noted, and there was also a retroareolar mass measuring 2.5 by 2.5 centimeters. So hopefully what you can appreciate is just in this short period of time between this image, it was about 5 months, and this image, there's this development of this asymmetry here. The other thing that I think you can notice in retrospect, or maybe more subtly, is there's also a lot of skin thickening around the nipple and extending inferiorly. In retrospect, this may have actually started to develop at this time if we compare back to here. I'm just going to move on to the ultrasound images. So you can see this is the left breast subareolar region. So you can see this was a very vascular area, almost anechoic, with lots of edema in the surrounding tissue. I think in some ways this looks similar to the last case that we just saw of granulomatous mastitis. And here again is this area, very echogenic tissue surrounding this very hypoechoic material right under the nipple. And this is just the upper breast, the unaffected upper breast, showing what her tissue looks like elsewhere. Again, lots of vascularity here. And here's a landscape view. Her lymph nodes were normal. Okay, and at this point, I'd like to ask the polling question. Okay, so you'll see this is actually the same question. That's not a mistake. Which of the following is most likely in this patient? Okay, great. So it looks like most people thought this was inflammatory breast cancer, which I think is a great thought. In this patient, I think the clincher here is actually, I did her biopsy myself, and her skin discoloration was actually quite remarkable. It was very deep, almost bluish purple. And I think that's actually a very key history in someone with a history of prior breast radiation. And this ended up being an angiosarcoma, secondary, thought to be secondary to her primary, previously treated breast cancer with radiation. So just for interest, I will show you the MRI. And this will just show extensive enhancement. Interestingly, that much of involves the skin as well as the underlying breast tissue, along with a lot of necrosis or non-enhancement. I think this is also very nicely demonstrated on these MIP sequences as well. Thank you for joining me. I'm really excited to show hopefully up to 8 cases today. Now, I will say that these are some very unusual and challenging cases, but I think they have widely applicable teaching points for everyday cases as well. So you should be able to see on your screen some routine mammogram views. I'll give you the history for this patient. This was a 31-year-old woman. This was her baseline mammogram. She has a 2-week history of right breast pain, a lump with mild transient erythema, and briefly felt feverish and chilled, and also experienced some yellow sticky nipple discharge. Physical exam revealed about a 9 by 13 centimeter firm right breast mass from about 8 to 10 o'clock and partially subareolar in location, was not fixed to the skin or chest wall. There was also a tender 1.5 centimeter right axillary lymph node noted. The patient is not pregnant or breastfeeding, and there's no family history of breast cancer or other related malignancies. So I'm going to show you the images here again. This was a right breast symptom, and here's the right breast images on the left side of the screen. I'm going to double click and enlarge this. So you can see there's some increased trabecular density and thickening, especially when compared to the same area on the left side. We see the same thing on the MLO view. I'm going to enlarge that. And you can also see an enlarged lymph node here as well. So the next thing we did was go to ultrasound. Here are the ultrasound images of the area of concern. You can see this was kind of the edge of that lump, and then more getting into where the lump is. You can see this very large area of hypoechogenicity. The overlying fat is edematous and the skin is thickened. And just going through that area here, even more edematous change and skin thickening. More of the same. And here's that right axillary lymph node. So at this point, I'd like to show the polling question for case 1. And the question is, which of the following of these diagnoses is most likely in this patient with these images? Okay, great. Looks like some of you got the right answer, and some of you got what is pretty much the primary differential. So this was granulomatous mastitis, and the main differential is inflammatory breast cancer. So just briefly about granulomatous mastitis. She actually underwent 2 ultrasound guided biopsies, which showed chronic inflammation, granulomatous inflammation, and even focal giant cell reaction. Several stains for various infectious organisms was performed and were all negative. This is an interesting and unusual scenario, although we seem to be seeing a lot more of it in our clinic for some reason. The etiology of this is still unknown. It's unclear. There are some thoughts that it could be infectious, that we just haven't located the organism. And there's also really no consensus regarding treatment. In our clinic, we tend to use a combination of steroids and antibiotics. There have been other reports of excising these, but as you can imagine in this young patient, this is a very large area and excision would ideally be avoided.